This is work that we did before the STAR project began, and it was led by Dr. Supervised, who is here, who was the principal investigator of the study. We implemented it between SESHA and PSI Zimbabwe. And we conducted the study among individuals who had come to the PSI Static Center at New Africa House in Harare, who had come to seek HIV testing. PSI also offer outreach services in different locations outside Harare, including rural areas. So we also conducted this study among the clients who came to the outreach testing facilities. And lastly, we also conducted the study among female sex workers who had come to seek HIV testing services at the National Sisters Program that is situated in Harare. The study had 4 aims, starting from developing the instructional materials that I'll talk about, and then looking at acceptability of self-testing when you give people the offer of self-testing versus provider-delivered testing, and some qualitative components. But for this presentation this afternoon, I will talk about the work that we did in terms of optimization of instructions in the general population and also among female sex workers. So firstly, aim 1, which was conducted at the New Africa House site, the static site in Harare, and also the rural outreach site in an area called Shamva in Mashonaland Central Province. What we aimed to do was to develop instructional materials that people could understand and use to accurately self-test, to produce accurate results when they self-tested themselves. And in aim 1, we were dealing with the general population at the New Start centers, and in aim 4, we're doing the same procedures of seeing whether people could understand the instructions and test themselves accurately, and this was among female sex workers. So what methods did we employ? Some of the methods are similar to what Malawi did. It was an iterative process where we started with a first draft of instructions, and then we changed it according to feedback that we got from participants in terms of what was clear and what wasn't clear. So first of all, we conducted cognitive interviews among participants at the static site in Harare, where a social scientist sat with a participant and went point by point on the instructions, to asking the participant to recall or to tell them what they understood each step of the instruction meant to them. And then after the participant has given this information, they would be asked to actually perform the test while the social scientist was observing and could notice what were problem areas that the participant was facing. When we came to a point where we were happy that we're not getting new information on how to improve the instructions from cognitive interviews, we then went on to a process we called supervised self-testing, where a person that had come for testing was given these self-test instructions and left to self-test alone in a private room and to actually record the results of the self-test. They would then give a finger stick blood sample for confirmatory testing and would compare the accuracy of the test by looking at the recorded self-test result and that test that is given by the healthcare worker in confirmatory testing. I should say that with this supervised testing, this was unsupported testing. The participant didn't get any prior instructions or any guidance on how they were supposed to do the test. They were just given instructions and left to self-test themselves. And we asked participants, for willing participants, we asked to put a video recorder during the process when they were self-testing themselves so that we could observe and see any challenges that they had when they were doing the self-test. So going on to more about cognitive interviews, we did 8 of them at the Harare static site, and this was mainly for the Harare. They were reviewing the first draft of instructions to see how people understood our initial draft of instructions. And then in the Shamva district, which was our rural facility for the outreach, we reviewed a major overhaul of instructions, which I'll come to in a moment. But just to say, initially we did 8 cognitive interviews, and then we moved on to supervised testing at the Harare site. So some of the insights from our cognitive interviews are similar to what Moses presented for Malawi. And the first one I'm going to talk about is the fact that just giving special instructions alone is inadequate. We had initially had a situation where we said, open the bottom pouch first, open the top pouch second. But this depended on how the participant was holding the pouch. So it was confusing for participants because they wouldn't know which one was bottom or top because it depended on how they were holding it. So we had to change our instructions to make that clearer. And we noticed that there were challenges with inadequate labeling as well, where it needed to be very clear how participants were going to open the pouches. We had some situations where we had to actually put arrows to make it clear which incisions participants were to use for opening the pouches. We also had challenges with the stand. The picture there, the brown cardboard, is the kind of stand that we're using during cognitive interviews. And we found that participants didn't always recognize it as a stand because it looked like it was an integral part of the packaging. So people sometimes didn't find it and they had problems understanding where they were supposed to put the container. Then we also had challenges with translations, and symbols were also a challenge, where this symbol that we thought was a do not eat symbol was interpreted differently, with some thinking that it was a plate that was on a stove, a cup that was on a stove, sorry. So going on to, after we had finalized our instructions from cognitive interviews among participants at the Harare site, we then went to supervised self-testing, still at the Harare site, and this was done among 172 participants between August 2014 to 15, and most of them, 86%, agreed to be videoed, so we had some insights from the videos as well. And we selected some of them according to that checklist of the videos that we could review. And from participants in Harare, when we look at the accuracy, looking at the final iteration that we used in Harare among the final 52 participants, we found that 93% of them got an accurate result when we were comparing the self-test with the confirmatory test result. And we were satisfied in general with the sensitivity and specificity information that figures that we got. And so we took out this version of instructions for testing among participants in the rural community. And what we found among the first 29 participants we recruited was that the results could not be replicated. People in the rural areas had challenges producing accurate results. 31% initially were not able to determine their results, and there were a lot of inaccuracies that we saw as well. So we looked at the videos to try to understand what challenges people were facing, because from the interviews we were not able to get more information. And what we saw from the interviews was that all participants read the instructions, and we could tell by looking at videos that those of lower literacy struggled in terms of going through the instructions. And when we looked at the reasons, possible reasons for unsure or invalid results, we found that people had challenges with the desiccant, where in some cases people would pour the desiccant crystals into the developer solution, and we had some who drank the developer solution or even ate the desiccant, which were some of the problems that we saw. And there were some spills of the developer fluid when someone could not find the stand where they could put the container. And then those are the other, I won't go through the specific, all the examples that are there, but based on this information that we got from the videos, we made decisions on how best we can optimize accuracy. One of the main things that we did was to make sure that we take account of the lower literacy that we saw in the rural areas. And this meant that we were supposed to have as little text as possible to facilitate understanding and have more pictorial instructions. So you see at the top of the slide, that was one of our earlier versions where we had a lot of text and very few pictures, but we did a complete overhaul of instructions at this point to have as little text as possible and many more pictures. So it is at this point where when we had this overhaul that we did an additional cognitive interviews with participants in Shamva district to see if they could understand the new pictures and the little text that we had introduced. And we found that after this overhaul, there was marked improvement in accuracy in Shamva district, where 90% of participants got accurate results, but we're still worried about the false positive results that we were getting, and we felt at that stage that we really needed to do something to enhance understanding of instructions, especially interpretation of results. So we came up with the idea to augment the instructions by a video, which we developed in conjunction with Ministry of Health, as Gertrude was saying earlier, so that we could ensure that it covered all the important information that Ministry of Health wanted to cover. And this video is short, it's about 3 minutes long, and it's so small that it can be shared via phones using WhatsApp. And after this video, we found that participants were happier and they could understand the instructional materials better. So our final package of instructions is a package which has both the written instructions, which are mainly pictorial, which go together with the instructional video. And we found that our accuracy figures were acceptable, and at this point we couldn't identify additional information that could be changed to improve the accuracy of the self-test. So we then took this package of services of the written instructions and the video to female sex workers, and we were very happy to find that the female sex workers were clever and they produced very accurate results. When we were looking at sensitivity and specificity, they had the best accuracy tests among, for all the participants, the groups of participants that we had looked at. So in summary, as has been shown also by Moses, in development of instructional materials, it's important to have an iterative process so that you address any areas where people don't understand. You could have cognitive interviews as we did, and supervised self-testing will be good as well so that you can see people's ability to produce accurate tests. And having a video during supervised self-testing is important because you may then catch some of the difficulties that people face which they may not report to you. We also, in retrospect, thought that it would have been more efficient if we had started with the least literate population. If we had started with the rural population, then we had a good package that we could take to more literate participants. It would have taken us a shorter time in terms of optimization of instructions. I've already talked about the importance of making sure that you have as little text as possible, and that the instructional video is really an important component of these instructions. I will end by thanking our study participant and the Ministry of Health, and also acknowledge our funders.